Welcome to Bullet Point Nursing. In this video, we're going to go through sepsis, your adult health or Medsurg nursing course, and obviously to get you prepared for the NCLEX. Let's start with the pathophysiology. We're actually going to be talking in this video about four different things: SIRS, sepsis, septic shock, and MODS. Let's start with SIRS. SIRS is a systemic inflammatory response, and it's an over-response by the body to some sort of negative stimuli. Sepsis is where a patient has SIRS and it's related to a confirmed infection. Septic shock is where, as a result of sepsis, of an infection, the patient ends up in a state of inadequate cellular perfusion. Generally, that's going to be related to the hypotension that goes with septic shock. And finally, MODS is where a patient has multi-organ dysfunction syndrome, and that's where the patient's organs start to fail. Let's look at the signs and symptoms. There's a whole bunch of them, and it completely depends what's going on. First of all, if the patient has sepsis as a result of infection, there's going to be very different symptoms if that infection is a UTI versus pneumonia versus MRSA of a wound. So it completely depends where the infection is. But generally speaking, the systemic effects will be fever, tachypnea, tachycardia, altered mental status, decreased urine output, and that's a big one because once we see decreased urine output, that often means that the body is trying to hold on to fluid because the body's heading in the wrong direction. Their skin may be warm and flushed early in shock and then cool and clammy later in shock, and they may even have hypotension if they're really getting into shock. The diagnostics to diagnose a patient with SIRS or sepsis are a bunch of different criteria. Some of this you don't really have to know as nurses. For example, SIRS, and this is not often taught at the RN level, SIRS is going to be diagnosed by 2 out of 4 different criteria. The 4 criteria are going to be fever, tachycardia, tachypnea, and an elevated white blood cell count. We're also going to check their CBC, and we're going to be looking at the white blood cell count there, as well as a few other numbers on that test. We're also going to look at a CMP. Like I mentioned, we're going to want to check how the kidneys are doing, so we're going to check their BUN and creatinine on the CMP to tell us if the kidneys are still functioning properly or if they're going into shutdown mode because they're not getting enough perfusion. We're also going to check blood cultures, and we're also going to culture any area that we think may be a source of infection, such as a wound, sputum, or urine. We're also going to check a lactate. Now, this is a good test question that you should be prepared for. A lactate greater than 4 is almost always going to be an automatic sign of shock. A lactate greater than 4 is generally an automatic sign of shock. And again, shock is a state of inadequate cellular perfusion. And that's a really good test for us because if a patient has lactate, that pretty much automatically tells us that the patient's in a state of inadequate cellular perfusion. Why? Because lactate is a byproduct of what the cells do when they're not getting adequately perfused, which may sound familiar to you because that is anaerobic metabolism. Next, we're going to check an ABG, an arterial blood gas. That's going to tell us if the patient's heading into metabolic acidosis, which is very often related to shock. And finally, we're going to check for any infectious source, such as checking a chest x-ray for pneumonia, a urinalysis for a UTI, etc. Next, let's look at your nursing assessment. For the patient that's in sepsis, that has sepsis or septic shock, you're going to assess their vitals first and foremost. You're going to look for any source of infection as part of your assessment. You're going to check their mental status. And if a patient is having a decreased mental status, that's a really strong indicator and a common test question that the patient is heading towards septic shock. We're going to check their perfusion and oxygenation. That's actually going to be 2 of our priorities that we're going to talk about in just a second. We're going to check their urine output to make sure that the body is still perfusing properly and not going into shutdown mode. And we're going to check their mean arterial pressure, which is a very common way that we monitor their circulatory status once a patient's becoming unstable. Our nursing priorities are going to be first and foremost to maintain their oxygenation and their perfusion. We need to make sure they're getting properly oxygenated, which may include putting the patient on a ventilator. In fact, pretty much everyone with septic shock is eventually going to end up on a ventilator. We're also going to make sure that we're monitoring their perfusion, and we'll talk about that in just a minute of how we treat that. Top nursing priorities after breathing and circulation is going to be early recognition of sepsis. This is huge nowadays in the United States that we must recognize sepsis as early as possible. Once we do recognize that the patient has sepsis, we want to immediately start fluids and antibiotics. We want to really quickly start fluids and antibiotics. Depending on the guidelines, somewhere in the first 30 minutes or so of recognition, we want to get both of those going. Now, one quick thing, because it's also a common test question, If a patient has sepsis, we're always going to get cultures, blood cultures, and those always must, big test question here, always must be drawn before you start the antibiotics. Even though you got all the orders at the same time, first get the cultures, then start the antibiotics, and all of that should be done in the first 30 minutes or so, or at least in the first 60 minutes. Next, let's move on to treatment. The treatment for sepsis is as follows. First, we want to immediately initiate broad spectrum antibiotics until we know 100% what the pathogen is that's making the patient sick. We're also going to immediately start fluid resuscitation. The patient who's in septic shock is going to be hypotensive for one primary reason. The sepsis, and to get a little detail, specifically the endotoxins that are released in sepsis cause major vasodilation. That vasodilation drops your blood pressure. It makes basically a simple way to think about it is your vascular system, your blood vessels became much bigger. So now instead of the blood filling up those vessels, the blood is the vessels are much bigger and the fluid is not filling it up. So the fluid is just the vessel's half full. So the fluid's just flowing, but not with any good force to it. So because of this massive vasodilation causing your hypotension, we need to immediately fix that. And we fix it by giving the patient fluids to sort of top off the vessel so that it's full again and the pressure comes back up. Additionally, we're going to give the patient vasopressors because, like I said, it vasodilated, so we want to vasoconstrict, and our go-to drug is going to be norepinephrine. The go-to vasopressor in septic shock is going to be norepinephrine. So once again, a patient who is diagnosed with sepsis is going to immediately be treated with fluids and broad-spectrum antibiotics, and if they're still hypotensive, they're also going to get started on a vasopressor such as norepinephrine. Generally speaking, because of the norepinephrine and because we want to really closely monitor their fluid volume, their cardiac status, we're almost always going to also put in a central venous line, a CVL, a central line, in order to monitor their central venous pressure and some other internal numbers. We also want to use it to infuse the patient with fluids and vasopressors if needed. Client education, there's really not much here that I think we would test on. The only thing I could think of to put there would be infection prevention. And finally, complications. We already said sepsis is what we were talking about, but septic shock would be the complication that arises from that. And then finally, MODS, where the organs actually start to fail because of their hypoperfused state. You're also going to see a term called a sepsis bundle. Sepsis bundle is where once a patient's diagnosed with sepsis in the United States, we automatically activate a sepsis bundle. In most every EMR, it's just going to be a button for the doctor or the nurse practitioner to click, and there it goes. And in that is going to have your fluids, it's going to have your antibiotics, it's going to have your blood cultures, it's going to have your nursing orders to frequently monitor their vitals, etc., etc. But if you see the sepsis bundle, that's what that's talking about. Hopefully this covered everything you need for class. Hopefully you do great on your test, and I'll see you in the next video.